so I'm here with Professor Jill Cook this morning. Hi Jill, thanks for joining us.
My pleasure, Rachel.
Jill, so we would like to talk to you today about tendinopathy. We'd like to have all your knowledge on tendinopathy, but before we start talking about that, maybe you could just, for the people that haven't met you before or heard from you, just tell us a little bit about what you do, where you've come from, so that we know how that's all come about.
Okay, well, I'm a physiotherapist by training and have been in research now for close to 20 years and mostly in tendon research, but a few other things as well. I'm 3 days a week doing research at a university and I do some clinical consulting on the other day.
Excellent. Which university are you working at?
I'm at La Trobe University in Melbourne, in Victoria, in Australia.
Yeah, good. And so you still do clinical work as well?
Of course, I think it's really important as a researcher that you keep yourself grounded by the people who don't get better. So our consultations are for the difficult and desperate and dateless, I call them, people who've had long-term tendon problems and are not getting better.
Great. So it's like a consultancy for people with tendon problems. Yeah.
That's right. That's right. We don't see people very often, but we like to consult with other physios so that they can sort of understand our approach and continue to progress the patient after that.
Okay. And just what has most of your research has mostly been on tendons? What kind of, is it all everything about tendons, or is there anything in specific that you...
Yeah, no, we've sort of covered most things. I guess we're not as interested in the treatment options. We haven't done a lot of research in that area. We're much more interested in, well, me particularly, I'm much more interested in understanding the pathology, the risk factors for developing tendinopathy, and the systemic factors that contribute to people's risk of developing tendinopathy. So that's sort of where we're interested. But I work with Sean Docking. He has a big interest in tendon imaging, and Ebony Rio, who has a big interest in tendon pain. So they're probably our two areas that we're working on most at the moment.
Okay, great. So now that we know all about you, can we start with the very sort of basic question of what is tendinopathy?
It's a really good question. It might seem really basic, but it's actually a very good question because I think it's used incorrectly a lot of the time. So it was defined back in the 90s as pain and dysfunction in the tendon. So what it means is it's a clinical diagnosis. Because we can't get tissue to see if there's degeneration or tendinosis, tendinitis in a tendon, it's best not to have a pathological term for the condition. So that's why we chose to go with a clinical term that really didn't rely on knowing what was happening in the tendon.
So the term tendinopathy is really an umbrella term for anything going on in the tendon. Would that be right?
It's an umbrella term for somebody who presents to you with pain and dysfunction in their tendon. And really understanding exactly what happens in that tendon is not that important to outcome. So there's quite a few studies that show that structure doesn't change very much with treatment, but people lose their pain and become much more functional. So that's data that's sort of come out more recently. So the original definition back in the 90s was actually accurate in that structure is not that important, and it's really how the patient presents to you that is important.
Okay, so we'll come on to presentation and things in a moment, but how does, because tendinitis, tendinosis, you've already mentioned a couple of those terms, how do they fit into this picture of sort of defining tendon conditions?
Well, tendinitis implies inflammation, and really that's been bedded down in the 70s originally, and right through the 90s and 2000s, people considered tendinopathy to be, or tendon pathology to be, non-inflammatory, making a little bit of a comeback in the literature of recent, but I still don't think there's really good evidence of it. Tendinosis means degeneration in a tendon. We published a pathoetiological model in 2009 to suggest that degeneration's end stage. So there are stages that a tendon goes through before becoming a degenerative tendon, but tendinosis usually reflects that end stage disease where the collagen is disrupted.
Okay, that's great. So you mentioned your the model that you published in 2009. That seems to be a sort of, I don't know, it seems to be a key turning point in our understanding of tendons or tendinopathy and how to manage tendinopathy. Perhaps you could tell us a little bit about how you came up with that model and how has that model sort of changed our understanding of how we manage tendon pathology?
It's really quite interesting because there's actually a lot of models out there. There's actually 7 different models of tendon pathology, so it's only one of those. Where I think it's made a difference is it makes sense to a clinician. So all of a sudden you can actually apply what you're seeing in the person in front of you to what we think is happening in the tendon. Now, it was developed over many years, probably 20 years of red wine discussions with Craig Purdom, and he worked with a young group of people. He saw one sort of clinical presentation. I worked with a different group of people, saw a different clinical presentation, and we started to talk about why we might be seeing different things. And all of a sudden we realised that because we both have an interest in pathology, we could actually put the presentations into some sort of order. And instead of just saying that tendon pathology was a single disease, a degenerative tendon, to actually say that there were stages that a tendon had to move through and to then attach clinical presentations to that, I think is why it's become so popular.
And so that model is, you've divided it up into 3 sort of
Yes.
presentation areas: reactive tendinopathy, disrepair, and degenerative. Perhaps could you talk to us a little bit about the 3 different stages?
Yeah. So I'll probably take it a step further in that we're hoping to publish an update of the Continue in the next few months, which would be good. So the model actually talks about reactive tendinopathy, where it's mostly a cell-based response and a proteoglycan-based response. As the condition continues to progress, the cell and the proteoglycans will disrupt the matrix, and the level of matrix disruption will determine whether it's in a disrepair stage and or a degenerative stage. So the more matrix destruction you get, the more it moves from disrepair to degeneration. Now, clinically, we talked about it being a 2-stage model and dividing up into an early reversible stage where there wasn't much collagen matrix disruption, and a later stage where there was a late disrepair degeneration stage where pretty much your collagen matrix is disrupted, and it's really hard, if not impossible, to recover that once it has been disrupted. We also talked in that stage of a combined state of pathology called reactive on degenerative pathology, which we will be updating. That is where a degenerative tendon is overloaded and the normal part of the tendon that's left actually becomes reactive. So we know that the degenerative area is mechanically deaf. That is, it doesn't change its structure very much, but we do get a reaction in the normal part of the tendon. So that's a sort of another stage that we now talk about.
So it kind of throws up a few questions for me, that model. So in the reactive stage, is that pathological, that stage?
Ooh, we would say yes, because there's enough matrix change and cell change to cause pain and to cause imaging change. So you can actually see the changes in the tendon. We have talked about it being reversible. So the changes aren't absolute to the tendon. That is, if you unload it, it can reverse. Sean Docking's research as part of his PhD actually showed earlier stages than reactive tendinopathy where we can see transient change in tendons, and Nicole Grigg's work does this as well. It seems that tendons do respond to load and recover within hours to days. That isn't reactive. So there's sort of like a transient or maybe adaptive part of a load response in tendons. So That's definitely not pathological, but a reactive tendinopathy is pathological.
Okay, and what sets off that reactive stage in a tendon?
Oh, very easy overload. There's
Okay.
no doubt that nearly every tendon presentation to a clinician will be traced back to an overload of some description.
Oh, that's easy. Good. And okay, so we overload a tendon and we enter into that reactive stage, which does enter a pathological, is pathological. Um,
Yes.
where does the pain come from that we experience?
That is the great unknown at the
Oh,
moment.
okay.
Uh, so there is a local nociceptive driver. So we know that from Ebony Rio's research. So she's shown that there are some central motor drive changes, not central sensitization, but some central motor drive changes. But you have to have your nociceptive driver. Now, as best we can determine from limited literature out there and limited research, is it's probably substances produced by the cells that are activated by the overload. That's a bit complex, sorry, but you overload tendons, the cell responds to the overload, produces substances that stimulate the nerves and drives the nociception.
Yeah, no, that makes sense. I think that's not too complicated. That makes sense.
Good.
Okay, but so we should look out for future work on that if it's the great unknown at the moment. But sounds like there's some work in progress there.
Yeah, it's a pretty hard thing to investigate. And that's why we don't have the answers, because animal models are not helpful, because we don't know when animals are necessarily in pain and we can't measure it very well. And we can't get early stage disease from humans. So someone with a reactive tendinopathy is not going to contribute their tendon to research. So it is hard research to do. And our imaging only tells us about the collagen. It doesn't really tell us very much about the cells, or doesn't tell us anything about the cells. So we can't see it in imaging. So it's tough research, and I don't know that the answer is going to come quickly.
Okay. We'll keep an eye out for that. So after this reactive stage, we've already talked about the disrepair stage and then the degenerative stage. And when we get to the degenerative stage, this is where the tendon starts to disorganize, the collagen starts to disorganize. Is that
Yeah.
correct?
Yes, that's right.
Yeah. And I guess in the degenerative stage, that's when it's longer term and more chronic, and more disorganization takes place.
Yeah, you've got longer term and chronic tend to be pain and clinical terms. So what we know is in a degenerative tendon, there is substantial disruption of the matrix. It has been there for months to years, sometimes many years. We have seen them develop over less than a year. So, but there's not much data or literature out there on just how long it takes for a tendon to become that disorganized. So yes, what it means fundamentally is that the matrix is disorganized. The collagen is no longer parallel. There's different types of collagen in the tendon. And as I said, it becomes mechanically deaf because you can't load the collagen because it has no structure. Then it's not load sensitive.
Mechanically deaf, I like that term. It's a good way of explaining it.
Yes.
Yeah. So you've talked about the time periods of each of these stages a little bit just then, in that you haven't really seen much of the degenerative tendinopathy sooner than a year after the problem started, perhaps. Can you put time periods on these stages or anything?
See, again, you've got to be careful mixing your clinical terms and your pathology terms, and that's where we often get caught with these. So somebody who has 12 months of pain may actually have had pathology at the start and have exactly the same amount of pathology at the end. What we don't know is how long the pathology takes to develop, because so much, about 2/3 of tendon pathology that develops, never creates symptoms. And this is our issue in trying to work out, how long these take to develop. And there are a few longitudinal studies, again, months to years to really get profound changes in tendons. But remembering that can be asymptomatic. So you can rupture a tendon. You have so much degeneration in a tendon that you rupture it, and you may never have had a symptom in your entire life. So again, we've got to be careful that we either talk about pathology or we talk about symptoms, and we don't necessarily mix the two as much.
Okay, I feel like I'm making it all complicated.
No, I don't think you are. I think it's how do I say it? It's common to do that, and that's why tendinopathy is such a great term, because it talks about pain function and it doesn't worry about pathology. And as I say, now we know that structure isn't that important in terms of prognostic factors. Then I think it's really important to talk about pain and function more than we talk about structure. So just using those terms around pain and function is the right way to be going.
Okay. So let's move on to when a patient presents with a tendinopathy or pain and dysfunction in their tendon, and they come into our clinics, what are we looking for with that patient? What should we be looking for, and how? Because obviously it's going to be important to stage that person so that we can manage them appropriately.
Yes.
What is it that we need to look for, or what do clinicians need to look for?
Okay, so really you're looking at all of the factors that can influence your clinical decision in staging that as a reactive or degenerative or reactive on degenerative tendon. So you're looking about the amount of overload. So was it an acute bout of overload? Was it a little bit more than what the person was used to? Do they have a history of tendinopathy? So if they have a long history of a grumbly tendon, you know it's going to be degenerative because they're just flipping in and out of reactive on degenerative all the time. You're looking at their age. So do they have a very active tendon? So young tendons are very reactive and very responsive to overload, whereas older tendons tend to be a bit more indolent. They don't really get worried about too much. Whether they're postmenopausal women, whether they're a man or a woman, all those things affect your clinical decisions about being reactive or reactive on degenerative. So for a true reactive tendon, they come in, they're extraordinarily painful. They tend to be younger athletes. They've had an abusive overload. The tendon's really swollen and sore. So the other end of the spectrum tends to be our reactive on degenerative tendons. It tends to happen in older people, but it can happen in young people because they actually can have degenerative tendons at a very young age. But it tends to be someone that's had a lot of load on their tendon. The overload that they've done is not as dramatic as our reactive tendons usually. They tend to have had a history of tendinopathy, as I said, grumbled along maybe for a little while, and they settle much more quickly. So a reactive on degenerative tendon will really become a lot less painful in somewhere between 5 and 10 days, whereas a truly reactive tendon can take 4 to 8 weeks to really settle.
Okay.
So, if you see a patient and you say, okay, just rest for a week, and they come back and they say, I'm much better, that's a reactive on degenerative tendon, because a reactive tendon won't settle that quickly.
Oh, interesting. Okay. And what about do people present with just pure degenerative tendons?
Very rarely, because it's not painful, because the degenerative area is, as I say, mechanically silent. It's not responding to load. The normal part of the tendon that is tolerating the load is doing very well. So these people will often have lumpy, bumpy tendons, may have had a bit of pain occasionally, but they don't present as pure degenerative tendons because there's no reason for them to present. They're not painful. Really is the reactive on the degenerative tendon that presents to us.
Yeah, so really we're only going to see the highly reactive first presentation tendons, and then the reactive on degenerative.
Pretty much. Yeah, I think I'd agree with that.
Okay, that's good. So then what do we do with those people?
Well, the reactive ones, because they're young and it's a new injury and we can recover it, we need to unload them from whatever caused the problem in the first place. And one of the critical things about treating tendons is never to rest them completely. always maintain a load that's not going to irritate the tendon. And Ebony's work on isometrics is fabulous because all of a sudden we have an exercise tool that we can actually use in these painful tendons, and they do very well with that. So we will always look to settle their pain with an isometric load. We'll take them off the high-level energy storage loads that usually create the problem. We'll monitor how many times a week they're active and really just make sure we pull the load down under the capacity of the tendon. In our reactive on degenerative ones, they will settle relatively quickly, as I said, so you don't have to do much to settle them. But what you actually need to do with those ones is improve the capacity of the tendon so that simple overloads don't keep stirring it up. So a reasonable example is somebody who doesn't do very much activity but needs to do a quick sprint, to catch the bus or something and gets a sore Achilles. So that tendon doesn't have very much capacity. So to stop that happening again, what you do is have to actually build the capacity in the tendon so that any load that they do is underneath their capacity. So it's sort of a slightly different approach, but it's still about maintaining the balance between what the tendon is capable of tolerating and the load that you put on it.
So where do eccentric exercises come in these days?
Well, it depends who you ask. If you ask me, I would say nowhere in isolation. So we don't use eccentric exercises in isolation. We use isometric exercises for pain relief and to relieve cortical inhibition. Then we use isotonics, which have eccentric component to it. Then we will use our faster exercises, so more towards our energy storage, which is probably a faster eccentric load. And then we'll do our energy storage and release loads, which is the loads that really affect tendons negatively. So we would never isolate out eccentrics at any stage along our treatment spectrum.
But you would do them as part of the treatment program, is that right?
As embedded in an isotonic exercise of some description. So every exercise we do will have a concentric eccentric part to it, aside from our isometrics.
Yeah.
So we don't do recipe programs of any description because every person with a tendinopathy who stands in front of you is going to be different.
Yeah.
You can't treat an old lady with Achilles soreness the same as a young athlete with Achilles tendinopathy. So you can't have one go-to recipe program. Yes. That's why we never used them, because it never fitted or any of our patients really that presented with the condition. And the important thing is that if we're aiming to return capacity to the tendon, eccentrics won't do it. You can't expect to be able to sprint off being able to do slow eccentric exercises. It's like asking a muscle to tolerate sprinting. If you give it very slow, steady exercises, it won't do it. You actually have to train it to do the loads or to tolerate the loads you want to put on it. So I can't think of too many sports or activities where you just do slow eccentrics. And so it's pretty much always going to fail you.
Okay, so we're talking about, aren't we, about modifying or giving out exercises that are specific to an individual person and the demands that they place upon their tendons. And
that's right. That's where you want to end up. But you've got to progressively increase your load from what the person is able to tolerate, what the tendon is able to tolerate when you first see them. You need to gradually increase the load up to what the person needs to be able to tolerate when they're returned to sport. So that's just exactly what we do. What can you currently tolerate now? What do you need to be able to do? We'll go from there to there over a period of weeks to months.
Yeah, and that progression over the weeks to months will be different for every single person who presents, because everyone's different. Yeah.
Exactly.
So we need to be when we're seeing our patients, we need to be taking into account their own personal circumstances and presentation and things like risk factors, which you've already mentioned a few already. Yes. What other risk factors should we be looking out for, or specific sort of circumstances?
Okay, so what we see in our older patients is often insulin resistance, type 2 diabetes, undiagnosed. That's very negative for tendons. High cholesterol is very negative for tendons. So both of those are linked to obesity, and particularly central adiposity. So that's definitely a risk factor. Menopause, as we talked about, postmenopausal women are very vulnerable to tendinopathy. Sean Docking talks about load appropriate change in your tendons. So we often ask people how much loading they did in their tendons when they were younger, because we seem to get change in tendons. There's a great study by Kujala that showed that sprinters in their 50s and 60s were 15 times more likely to rupture their Achilles tendon if they were sprinting when they were young compared to wrestlers. So it seems that a lot of use on your tendons actually predisposes you to tendinopathy later. So many factors that you have to consider. You have to consider seronegative disorders. So do they have ulcerative colitis that might be impacting on their tendon? You have to consider other injuries. So often we see tendinopathy arise after they've recovered from another injury. So what's happened is you've unloaded the tendon because of the other injury, you've dumped them back into a high load environment and they get into trouble. So many things.
Yeah, okay. There's a lot to look out for, isn't there? So, and it just
Tons.
highlights the importance of individualized treatment or management programs, or managing your patients as an individual.
Absolutely. And a really, really good history and clinical examination. Far too dependent these days on pictures. And as we've talked about, structure doesn't make a big difference in how we treat our tendinopathies, especially the degenerative end of the spectrum. So whether somebody presents with, horrible looking tendinopathy on their ultrasound or MRI, probably shouldn't change our treatment that much. It's really about assessing the patient well and working out what they want, and then instituting, as you say, an individualised program.
Yeah. So, I mean, you've already mentioned a lot of the risk factors, and that comes into the detailed history taking. With the clinical assessment, now this is a really difficult question, I think. We're talking about tendons in general and no specific area. Is there any kind of clinical test or assessment technique that is useful?
Yes, so simple. You need to assess their function. Exactly what we do as physical therapists or physiotherapists is, and you particularly need to have a look at their high-end function. So tendons will be strained by energy storage and release loads. So you need to look at how good they are at that, what their strength base is, what their strength endurance is, all of those things, how their kinetic chain functions. All of that is so critical to managing or assessing and then managing a tendinopathy. There is no point in looking at the pictures. There is no point in poking the tendon. Neither of those give you anything that you can actually work off. You actually have to work out what the capacity of the tendon, the muscle tendon unit, and the kinetic chain is, and then fix it. So restore function.
Yeah. So when you're assessing their function, are you looking for for want of a better term, point of failure, or?
You're looking for the relationship between increasing the load on the tendon and pain.
Okay.
So you will increase the load on the tendon to a point where you don't want to do it anymore because they've had quite substantial pain from it. So that gives you a really good understanding of what the base ability of the tendon is. So for some people, it might be a double leg heel raise for an Achilles tendinopathy, an older person who's overweight and hasn't done much loading and has got 8 out of 10 pain going up on 2 toes, on 2 feet. Not going to assess very much more than that. But a young sprinting athlete, you might do hopping and forward hopping and change of direction stuff to elicit their pain and to elicit that level of function. So again, even your assessment's going to be highly individualised.
Okay, that's really useful, I think. So function, folks, is the way to look at these things.
Yep.
Let me ask you about biomechanics.
Mm-hmm.
Does that have an influence?
Depends what you mean by biomechanics. So there's very little evidence of pronations associated with tendinopathy. There's very little evidence of, biomechanics being a big player in the onset of tendinopathy. Your biomechanics change because your function changes, so it will be different in people with tendinopathy because you often have strength deficits, endurance deficits, energy storage deficits, kinetic chain deficits, so your biomechanics change. And you do have to restore that, but you restore that by assessing and managing their function. There are a couple of tendons where mechanics are much more important. So gluteus medius tendinopathy in older women is about how you walk. particularly in terms of the compression that you apply around the hip, and tib post in older people as well, where the foot posture is really critically important. But on the whole, we don't spend a lot of time assessing someone's biomechanics. I know there are people out there that do, but on the whole, we're looking to restore mechanics back to at least the other leg and up to the level that they need to function. And that's all. That's pretty much all we do.
So again, looking at bringing people back to their own individual normal functioning.
Yes.
Yeah. What about medication? Analgesia, anti-inflammatories, do they have a place in the treat management program?
There's not a lot that changes substantial tendon pain. We've been there, done that, tried that. We have athletes with tendon pain. We've tried every medication under the sun. There's a suggestion that combinations, the polypill, the tendon polypill, can have an effect on how the cell responds. Probably our best cell moderator, if that's what we're trying to do, if cell activation is what creates our nociception in the first place, then our corticosteroid medications are very good at cell modulating, but we have to be very careful how we use them. We have to use the right medication, the right corticosteroid at the right time. That's pretty much the only really good disease-modifying agent that will have a substantial effect. So our nutraceuticals, people talk about omega-3s and our curcumins and those sorts of ECGC. They all have roles to play, but they don't have profound effects on tendon pain.
Okay, so when we're talking corticosteroids, are you talking injection or?
Doesn't really matter. You can really give it any way you want. Please, we have to be so careful. There is a time and a place. We probably resort to it once a year in the people that we see. It's somebody that's got a terribly painful, out of control, reactive tendon, and you don't have any time to change it. They've got a grand final in 3 weeks. All the caveats of corticosteroid, we know that they give longer term poorer outcomes. We know you can rupture with them, all those sorts of things. It's not something that we would ever do lightly. So I shouldn't have mentioned it in the first place, but
Sorry.
Now I have. You have to be so considered. It is not a go-to treatment. It is a get out of jail free. No, you don't even get out of jail free. You get out of jail with some potential for harm when you need to.
Yeah, I think the comment from that I would probably say is that if you're only using that once a year, we should probably never be using it. We probably won't see that person, or it's highly unlikely.
I think the clinical decision making around that is really quite complex, and the education and the buy-in from the patient is really, really important. But it will only be in an extreme elite environment where you just don't have any options where you would use it.
Okay. So moving on from medications, what about nutrition?
So we sort of touched on this, where some of our antioxidants, our EGCG, omega-3s, our TGF-beta inhibitors, our curcumin, that sort of stuff can play a role, do potentially have a role, but they're 5%ers. They don't change a tendon. You don't take EGCG one day and wake up the next day and your tendon's better. Because if you remember what we talked about, it's changing function and capacity that's really important. So they're really good adjunct treatments, or things that you add to help you get where you want to go, but they never can underpin recovery.
Yeah. So I think I'm going to ask you one more question in a minute, and I think the answer is going to be the same. But I think what we're always coming back to here is that the main modifying factor that we should be looking at is the load modification, and then bringing the load back in appropriately for that individual person's function.
That's right. If you want to run a marathon, you have to have tendons that tolerate running a marathon. If you want to play golf, you have to have tendons that tolerate playing golf. And your job as a physiotherapist is to restore that function pain-free in that person. And unless you do that, then the person will be a recidivist tendinopathy person. They will get pain again and again and again and again.
Yeah, and everything else around that is just adjuncts, which you've been talking about.
Yes.
So medications, nutrition, and electrotherapy, question mark?
Well, really, at the risk of being impolite, probably not going to help you at all.
Okay, because there is some talk out there about if you're really specific and if you're taking individual circumstances that perhaps laser or shockwave may be appropriate, but they...
Okay, yep. So laser has an effect on the cells. So it will increase the energy of the cells. I struggle if in a tendinopathy state we have hypercellular, hyperactive cells anyway. But there is a couple of randomized controlled trials that show that it alters pain, so maybe it changes our nociceptive output of the cells. ESWT appears to have an effect on our nerves, so our C fibers in particular. So it disrupts the transmission of our nociception to our brain. And there is a little bit of evidence that actually is negative for structure. So there's a balance there. Again, can be appropriate. You have to choose your tendon. You have to make very good clinical decisions as to why you would use it.
Yeah. So again, shouldn't be a standard management option.
No.
And we're heading back to appropriate loading or loading and unloading at the appropriate times to restore function.
Yes, absolutely.
Yeah.
I think you've nailed it.
Yeah. Okay. So I think we've covered a lot there. We've covered the physiology assessment and management plans, management options. You talked earlier at the beginning about an update to your model that you might be publishing soon. And I was also wondering about other current and emerging concepts. Is there anything that you might be able to share with us?
There's certainly Sean Docking's work is really important in this area, where he's shown that the normal tendon, or a tendon that has pathology, adapts and has enough or more normal tissue than a normal tendon. That is, we don't have to worry about the area of pathology because the tendon's actually adapted and has produced somehow enough normal tissue. So that's really important because it takes away our focus on structure and changing structure. We actually have to put our focus on increasing the capacity of the tissue that is already there and capable of tolerating load. That's really important. And Ebony's work on isometrics is fabulous. So we've absolutely changed our ability to change people's pain immediately, and the fact that we can improve cortical inhibition is really important as well.
Okay, right. So we will look out for those. We will do some reading around those as well. Respectful of your time, I know I've been chatting for a while. Is there anything else that you would like to share with everybody out there? Any final messages that you would like to say?
All I want to say is be good clinicians. Don't get sucked into simplistic models of assessment or management and recipes. Assess the person in front of you and treat them appropriately.
Individualised management of your patient.
Yep.
Okay.
That's it.
Brilliant. So Jill, thanks so much for talking to us today. It's been really insightful. Is there anywhere that we can find out more about you and the work you're doing?
No, I tend to hide. No. The answer. Read the papers from my group, I think is pretty much the only way. We do courses all around the world, so we've got a very busy 2016. That's where we have 2 days to actually talk through these things. We're not trying to do it in 30 minutes.
Yeah, exactly. So where can we find out where your courses are? Anywhere in particular, or are they randomly everywhere?
They're randomly everywhere. We are getting ourselves a bit more organised, so hang about, and hopefully sometime in the new year we'll actually have some sort of website that you can go to.
Okay, well, do let us know when you have that and we'll share it with everyone.
Will do. Thank you so much for your time.
Thank you. Thanks, Jill. Thank you so much for talking to us today.
My pleasure.